Hi, welcome to Case of the Day, and today is the 20th case. So we've done 5 weeks, and now I'll come back next Monday. And today's topic is, or the title is, the role of CT and CT guided biopsy in spine infections. And I had this 61-year-old treated CA breast backache and had a PET CT. It was about a week or 10 days ago, and you can see these osteolytic lesions here with the abnormal soft tissue. It's a discovertebral lesion, so it's characteristic of an infectious spondylitis. A biopsy was done, was negative. Then an MR was done 4 days ago, which clearly shows the infectious spondylitis, the perivertebral collections, the anterior epidural collection. And the patient was referred for a repeat biopsy for two things. One is to rule out metastatic disease convincingly and to obtain material for culture sensitivity and PCR. The CT that I did in the morning just prior to the biopsy clearly shows sequestra, which confirms that this is infection, and it helps you plan the biopsy because then the idea is to go through one of these osteolytic lesions, either the superior end plate of L3 or the inferior end plate of L2, and I thought L3 is better. Um, Plus, there was this collection here, and I thought in a single trajectory I might be able to get both. Remember, in the elderly, even in India, non TB infection is commoner than tuberculosis, and so we have to take for everything. So, in the prone position under sedation, this is the local anesthetic injection, but the patient was already sedated. So, remember, I need to do this osteolytic lesion and then this collection distally. So here's the 11 gauge. This is perifacetal. The nerve root comes out here, so you have to be a little careful. I injected a lot of local anesthetic here to both create hydrodissection as well as to anesthetize the nerve. Then, using a hammer, went in. Once I was in the osteolytic lesion, I aspirated pus like material, then advanced it into the collection, got more pus like material, then withdrew it back into the osteolytic lesion, and then through the 11 gauge inserted the 18 gauge bar and biopsied the tract and the soft tissue, and then withdrew this a little more and continued doing the biopsy. And that's the track through the or that's the biopsy track. And that's kind of the summary, right? First in here, then further down, then the biopsy, and then the track. So the pus-like material was sent for TB PCR and TB culture, aerobic culture, and fungal mycolytic culture, and Biofire. Now, Biofire is also a PCR technique that looks at a whole host of bacteria. A lot of people do Biofire for viruses during acute respiratory illnesses, but you can also do Biofire on pus-like material or pus from the spine, from the joints, etc. And typically you get an answer if positive in about 24 hours, whereas the rest take longer. TB PCR also comes in less than a day. And so we'll wait for the answer. The cause was sent for histopath, and I'll post the answer as soon as I get it as a post on YouTube. But it is important to pay attention to a spine biopsy in suspected infection and take enough material. Plus CT, when it shows sequestra, can confirm an infection, especially if the MR is indeterminate. And I talked about spine biopsies in case 12 when I looked at these two patients who had both presented on the same day, both with D10 lesions, this one was suspected to have a path fracture, but it was osteoporotic. This was suspected to be osteoporotic, turned out to be a path fracture, and I biopsied this, and it's still negative for gene expert and culture, but the histopath has shown granulomatous disease. I did this lecture and I've just posted it on YouTube. I'm going to try and put up a card on the top right corner, but I don't know if I'll succeed in that. But anyway, there'll be a link in the last couple of seconds of this lecture that you can follow, and I'll put up the link also in the below where the description is. This is at ctbiopsy.com, but the lecture is on YouTube as well. And similarly, this was about 3 years ago so the earlier lecture is about biopsy in patients who have spine infections. And this was in an infectious disease conference, whereas this one is just general spine infections, and a link to this lecture is also there at the end as well as in the description, WhatsApp channel. Thank you so much for listening.